In today's episode of the 340 Banter podcast, we discuss how health centers document clinic-administered drugs and some considerations for adapting to manufacturer-specific requirements and the implications of a potential rebate model.
Welcome to 340 Banter, a podcast dedicated to exploring the journeys, challenges, and successes of our 340B community. Our goal is simple: to engage, inform, and empower you to make the most of your 340B program. In each episode, we discuss real-world experiences and opportunities across the worlds of pharmacy and 340B. You'll hear from industry leaders and experts as they share insights and explore the impact on covered entities, pharmacies, and the communities they serve. This podcast is produced by Grit and Gravel, your partners in marketing strategy and success. Now, let's get to the banter.
With clinic-administered drugs, unlike hospitals who have medical records that really track to the patient's bed and barcode scanning, our software, the electronic medical records in the health center are not really meant to track a drug to that point. So often health centers use a paper log or an Excel spreadsheet, which meets HRSA's requirements for auditable records. However, it's becoming a little more challenging because we're seeing some changes in the space with manufacturer restrictions and a possible rebate model that would require upload of claims to a certain platform, which is going to be challenging with a paper log. It's going to create additional workflows that health centers have to work through and develop a process for. So I think it's going to be, from this point on, really health centers are going to be obligated to really look into ways to adapt their processes to really meet the current needs of the program.
Yeah, I think that it helps to frame the situation by thinking of how health centers bill differently than hospitals, because I think a lot of the framework for claims monitoring and submission has been based on the understanding of hospital billing practices. So drugs get placed onto a hospital bill as specific line items. And that ties back to the need for their barcode scanning for each individual drug administration, and which is how we get our auditable records in the case of many hospital administered drugs. And because health centers are largely reimbursed at a bucket rate, or at a
bundled payment.
Bundled payment. Thank you. Bucket was the wrong word. Bundled payment. They're not billing for those drugs separately, and most of the time they're not listing them on the claims at all. They just bill for the visit, and that's it. And they're reimbursed at a bundled rate.
Yeah, so that goes for Medicaid and Medicare. Yeah, they get the prospective payment system, or PPS. And they get a flat rate no matter what they do in that service. So it really didn't make sense to have to put the work in to bill each line item of the drug, because they're going to get paid the same amount. Yeah.
So because those aren't going onto a specific line item or onto a bill, the manual tracking in a paper log or in an Excel spreadsheet of this is the drug that was administered. It was administered to this patient on this date by this individual, by this health care provider, meets all of the 340B HRSA auditable record documentation needs. And there often is documentation in the chart, but it's not always in a discrete reportable field, and it definitely doesn't have the information or data around billing elements. And when we look at the requirements that have been in place so far for medical claims for the manufacturer restrictions, we do have the health claim bill line number and the health claim ID, and those just don't exist now. So for health centers, it's honestly they're really going to be making up or creating data where it has not historically been, because they don't necessarily have a bill to tie that prescription, or that drug administration to. And from all of this, the place that health centers are going to be kind of stuck in is for the manufacturers that so far have placed these restrictions on needing to submit medical claims data in order to be able to continue to access 340B pricing, if they don't submit those claims, they may be at risk of losing their 340B pricing, not only for clinic-administered drugs, but entity-owned pharmacy drugs, contract pharmacy drugs. It holds a large risk. So the question before health centers at this point is, do they start looking at some of the technological advancement options to get a lot of their drug administration records into a system or a program that could readily report what information is available? It's still not going to correct the billing line item number issue, but it would facilitate easier documentation reporting. Or did they look at what their ultimate savings is on purchasing drugs at 340B for their clinic administered environment and say, okay, this is what it would cost us to implement a new system or hire a person to transcribe all of our paper logs into an electronic mechanism? And does that outweigh the loss we would have if we just chose to purchase all of our clinic administered drugs on our non-340B GPO retail, whatever it might be, account?
Yeah. And I think before you make that consideration, we definitely have to advise you, talk to your state or check your state rules, because there are some states that do require you purchase everything under 340B. Or if you're in a Medicaid exclusion file only state, that creates problems because if you have one drug, then everything's excluded. So you really have to do all 340B at that point, or no 340B. It's an all or nothing. So I think it's really important to check that. But we've had those conversations a lot with people even before the new manufacturer restrictions.
Yeah.
Is that sometimes it's not worth the savings if it's only $1 per bottle. That may not be worth it for the compliance risk. So you really need to weigh the risk versus benefit, and whenever possible, try to limit where you're using 340B to if there are issues with maintaining that documentation and struggles with that process.
And I think it's important to remember, for folks that have been in the larger 340B system, to remember that health centers, as well as some of our more rural hospitals, are not subject to the GPO prohibition. So when they identified that they're going to utilize 340B, they are not required to use the same. They're not required to use 340B to purchase the same drug across all venues. If you purchase it in your retail pharmacy at 340B, you don't have to do the same thing in your clinic. And you don't have to say you're going to purchase all of your clinic-administered drugs at 340B or none of them at 340B. Again, subject to state Medicaid nuances. But you are able to, as a health center and as some of the more rural or smaller hospitals, able to identify which drugs you'd like to include in your 340B program. Many health centers have gone to, a model where they pretty much just utilize the 340B program to purchase their long-acting reversible contraceptives and their long-acting injectable antipsychotics. Because and now HIV and you're right,
treatments and prevention.
I forgot they've added those in.
And the other one we're seeing is drugs for substance use treatments.
So the benefit for those is much more substantial. The difference between 340B and non-340B price is really significant. But also because by the nature of them being an injectable or a device that's implanted, there's something. The way that the encounters are built within even though they are less advanced medical record systems than what some of the larger hospital health systems are utilizing, those drugs, those procedures have more discrete fields to document in. And so they're easier to generate reports out of those medical records based on J codes or something like that, to be able to get some of the more automated reporting that you would need to upload into the platforms for the manufacturer restrictions or a potential rebate model.
And that's kind of my first rule. I start looking at the J-code drugs, the injectables, because they are trackable. And then from there, I pare it down from there. But if there's a J-code or a CPT code, it makes it a lot easier to find it in the medical records. I would say something else. Currently, it's a lot more feasible to continue your current practice and maybe just limit these drugs because it's only a couple manufacturers right now.
Yeah.
But I would say even if you're not using any of the drugs for those effective manufacturers at this point, I would really start thinking through this because from what we've seen in the past with contract pharmacies, this is likely to grow to additional manufacturers and it'll eventually get to the point where it could affect drugs you're using in your clinics.
Yeah, and we've had some organizations that have looked to change their formulary for their clinic administered drugs. They did that when it looked like the rebate model was going to roll out. And then they've had to flip back now that the rebate model has been withdrawn somewhat temporarily. And different manufacturers have now imposed these clinic administered drug requirements as well. So then they've had to switch back and recognizing that that's not necessarily sustainable for an organization.
Good for patients.
Yeah. And not everything is equivalent. It's not, isn't great for patient care. So as you said, kind of taking the time now to say, okay, we're at the tip of the iceberg. This is where we should pause to evaluate our situation, our scenario. And if we decide that, okay, there is a tipping point for when we would consider not utilizing 340B for clinic administered drugs, or this is when we would want to look into implementing a different system for tracking. Having that decided before you're in crisis mode is really important. And in terms of looking at other systems that are available, without kind of going into specific names of systems, what are places that health centers can look to for potential solutions?
The first and most obvious is talk to your EMR vendor. There may be add-ons, modules, or maybe it's something that's already pre-built that you can kind of adapt. We heard of a software where they were able to use a therapeutic injection classification even with oral meds. So they
use the kind of like their vaccine tracking system within the medical record for all of their clinic administered drugs, even those that were orals.
Yeah, and it didn't require any additional costs. So that's ultimately the best option. But your EMR vendor, certain wholesalers have options that they will sell. Even if you're not a customer of that wholesaler, you can buy these freestanding options. And then there are some freestanding companies that have barcode scanning and other types of tracking mechanisms.
Yeah. I think some of the companies that do like the automated dispensing cabinets that obviously health centers don't use those as often. They're typically used for hospitals, but those companies do, I believe, offer kind of a pared down version of their system that could be helpful. And really important when you're looking at these options to find out, is it a monthly fee for software? Are you purchasing hardware? Are you renting hardware? And what does that mean? What would implementing this mean for your workflow, for your staff? Because you can make a change based on requirements, but if it doesn't work with the staff workflow, they're not going to engage, they're not going to comply with it, and it is not going to have your expected outcome, and you've in essence wasted money.
And I think the biggest thing we've seen on external audits when we've been out in the real world, when we're seeing these solutions in action, is that the biggest problem we see is that people assume that they are automatic, and they aren't. They do require
not a set it and forget it type
yes, exactly.
situation.
They require a lot of maintenance and monitoring. So really finding champions, and what I think, especially in the health center space, if you can find champions in your nurse team, that is going to make or break you. Because nurses are very meticulous at what they do. And if you can get them on board, they'll fight for any program you have, especially if you can show them that it's going to save them time. Yeah.
I'll also say that if you have an entity-owned pharmacy and you have a technician champion or a lead technician, having them step into a role where they can help manage the clinic administered drugs. And if there is additional oversight or management tied into any new system, that is a much appreciated role.
And
I
they
suppose that
understand
the
it.
pharmacy
Yeah.
staff can help support the medical staff so that we're not adding additional responsibilities on an already taxed system.
Yeah, exactly. And a lot of these, I think when you're setting them up, you really think about workflows and try to. What I've done when I've evaluated any changes in clinic administered drugs is I follow the nurse and watch their process for a day.
Yeah.
So I can see what they're doing. That way I can provide as minimal interruption to their workflow as possible. And I think that that's just a good process overall whenever you're making a change to the nurse's job duties.
Yeah, definitely.
Thank you for listening to 340 Banter. This podcast is produced by Grit and Gravel, your partners in marketing strategy and success.